Okay, so hi guys. I know many of you are giving university exams now, especially the Kerala students. Okay, so many of the students are giving university exams. So there are a lot of queries on how to answer various questions. Okay, so today the topic that I've chosen is how to answer leukemia question if it is coming to you in exam. So guys, whenever I'm talking about leukemia, you have to understand what you understand by leukemia is that there are some malignant cells. So malignant cells in hematology are called as blasts. So they are filling the bone marrow. And when they are filling the bone marrow means their number is more than 20%. So because their number is more than 20%, so all the other residual cells are going to decrease. Okay. All the other residual cells are going to decrease. Okay, so what is going to happen is the patient is going to have decreased WBC, decreased RBCs, okay, and decreased platelets. So patient will present with, because normal WBCs are decreasing, they will have repeated infections. Okay, and because RBCs are decreasing, they will have fatigability. Okay, so they'll be having fatigue, and because platelets are decreasing, so they'll usually have bleeding, and especially the bleedings are from the gums. Now, why I'm telling you this is because majority of the hematology questions will be your clinical based questions. Okay. So how to approach a question? First, you have to make a diagnosis, and how to approach the correct diagnosis. Both are very, very important. Okay. So now how to answer the question? No. So first, identify that what is the case. Once you have identified any case, okay, then after that you start focusing. You should know how to answer it. So for any pathological question, go by these headings. Okay, so first always write what is the etiology of the case. Okay, number one. Number two, second point, you write what is the pathogenesis. Even if you don't know the answer, write these headings. Okay, because these headings are going to give you a lot of score. Okay, so etiology, pathogenesis. Okay, and lab diagnosis. So whenever we talk about lab diagnosis in hematology, this goes under three headings. One is morphology and blood counts. Okay, morphology and complete blood counts. Second, is there any special test? Okay, is there any special test that you can do? And the third, what is the diagnosis of choice? What is the diagnosis of choice? So this goes for the diagnosis. And after that, if you know that what is the prognosis of that condition, okay, is there any factors which affect the prognosis, and treatment if you know. Okay, so these are the basic headings in which you should write. If you write no, 100% you're going to get good scores. Remember, etiology, pathogenesis, diagnosis, prognosis, and treatment. And in diagnosis, write morphology and special test, and diagnosis of choice. Okay, now let us go case by case that what questions can be asked you in exam. Okay, so whenever I'm talking about leukemias, no, so first you have to identify the diagnosis, and then only you can write the other part, isn't it? So remember, there are only two type of leukemias that can be given to you. Okay, either it can be an acute leukemia, or they can be chronic leukemias. Okay, so chronic leukemias or acute leukemias. So, in hematology, the criteria for acute and chronic is very simple. Okay. So, in acute, what happens is that there is block in the differentiation. So, because of that, the immature cells are increasing, and usually the immature cells are more than 20%. So, you will have more than 20% blast. Okay. So, that is majority of the acute leukemias are because of block of differentiation, and maturation is not occurring. Whereas majority of the chronic leukemias are because more and more proliferation is happening, so more and more cells are coming out. Okay, so here the blast count will be always usually less than 5%. Okay, so blast will be less, but the mature cells will be more. Okay, so there will be more mature cells. So first, that law should be very, very clear to you. So once you see in your question this line, there are blasts more than 20%. Immediately you should start thinking of acute leukemia. There is increased leukocytosis with more mature cells. Immediately start thinking of chronic leukemias. Now let us see how further we can divide. See, in acute also we will have two categories here. You know, in hematology there are only two type of cells, myeloid and lymphoid. Okay, myeloid and lymphoid. Same way in chronic also, myeloid and lymphoid. Please mind you, I'm right. We are talking this as a simple undergraduate university level question. Okay, so we have acute myeloid leukemia, we have acute lymphoid leukemia, we have chronic myeloid leukemia, and we have chronic lymphoid leukemia. So these are the four categories. Simple. Now, once you see more than 20% blast, now immediately go to the second heading and look at the age. Okay. So now, whenever we're talking about lymphoid cells, we have two types of lymphoid cells. We have B lymphoid cells and we have T lymphoid cells. Okay. So suppose they give you age between 1 to 10 years. Immediately your diagnosis should go between B lymphoid cells. So age between 1 to 10 years, go for B lymphoid cells. They changed the question to adolescent age. They changed the question to adolescent age. Immediately start thinking of T cell. Okay, so T cell ALLs. Apart from that, B, whenever I'm talking about B lymphoid leukemias, they usually go to the lymphatics. So they'll present with lymphadenopathy. So 1 to 10-year-old child presenting with lymphadenopathy, immediately your diagnosis should go towards B cell ALL. Okay, whereas T cells name is thymus, so it goes to the thymus. So they usually present with mediastinal masses. They usually present with mediastinal mass. Okay, mediastinal mass. Okay, so that is simple. Adolescent male presenting with mediastinal masses, immediately your diagnosis should go towards T cell ALL. Okay, so think in your mind what is the question is going to they're going to put adolescent with mediastinal mass. Okay, now, or first 1 to 10 years with lymphadenopathy. Then we are clear with this. Okay, we are clear with this. What about myeloids? So whenever I'm talking about myeloids, no, myeloid is a big family. But for an undergraduate, you should remember here that what all they can ask you in exam is majority of the myeloid patients usually present with splenomegaly. Myeloid cells go for maturation to it's them spleen. So they'll present with splenomegaly. Now here we should know, suppose every acute myeloid leukemia has a particular characteristic. But one of them, which is a medical emergency, and they can give you as a question, is acute promyelocytic leukemia. Acute promyelocytic leukemia is a medical emergency because it presents with DIC. It presents with DIC. So if they are giving you a patient presenting to you with bleeding DIC, always think of APML. Okay. Now, next, you should remember monocytic leukemias. Monocytes have a tendency to go to the tissues, isn't it? So suppose they are saying that there is leukemia cutis, gum hypertrophy. Okay, leukemia cutis gum hypertrophy. Then immediately your diagnosis should be it is monocytic. So in monocytic, it can be M4 or M5. So these are the important one in myeloid that they can ask you. It is the important one in myeloid that they can ask you. So once you're clear with this, let me ask you a question. Okay, so let me ask you a question here. So suppose I'm saying here, 2-year-old child with lymphadenopathy. Okay, now because these are acute leukemia, the blasts are in the bone marrow. So what is going to happen? The blasts are in the bone marrow, so other cells are going to decrease. Presenting with anemia, repeated infections, and bleeding gums. What is your diagnosis in this case? Once you see this 2-year-old child with lymphadenopathy presenting with fatigability, anemia, they'll give you repeated fatigability, infections, bleeding gums. What is your diagnosis? So this is lymph node. So it has to be B cell ALL. Okay, that's your diagnosis. You made your diagnosis. Now let's go to this. Adolescent presenting with mediastinal masses. Okay, adolescent presenting with mediastinal masses. Again, three things that you should remember. I'll write it as fatigability, repeated infections, and bleeding gums. Your diagnosis quickly, everybody. T cell ALL. Perfect, guys. Now, let's go to the third. Okay. So, myeloids usually present. Okay. They can present at any age. They can present at any age. But usual age group is about 20 to 40 years. Okay. So, myeloids can present at any age. But usually the age group is 20 to 40 years. Okay. And now, if they are saying that 20 to 40 years old child presents with 20 to 40-year-old child presents with again. Okay. Let's say DIC plus repeated infections, again, infections, bleeding, and fatigue, then immediately your diagnosis will go for APML. Okay, I'll change the question. Present with infections, fatigability, and bleeding, plus spleen is also there. Okay, in this also splenomegaly will be there. In APML also splenomegaly can be there. Okay, plus there is gum hypertrophy. Okay, gum hypertrophy, leukemia cutis. Then what is your diagnosis? Think of AML, M4 and M5. That's about acute. That's all that they can ask you in university about acute leukemias, guys. Okay, so you should be very clear in this approach to identify the acute leukemias. Once you are clear, now let's come to the points. Once you have made your diagnosis, now let's see how are we going to approach. For the university exam, these are the headings in which you're going to write the answer. So first, go for etiology. Etiology is common in any leukemia, acute myeloid or acute lymphoid. Okay, you have to remember three etiologies, at least you should remember. One is radiation. Okay, acute leukemias are very common after radiation, especially myeloids. Viral infections, okay, especially HTLV1 can produce adult T cell leukemias. Okay, drugs, alkylating agent, topoisomerase inhibitors themselves, they can cause cancer. And of course, some syndromes like DNA breakage syndrome, in which DNA breaks and therefore it doesn't repair and can cause leukemias, like Fanconi's anemia, ataxia telangiectasia, okay, ataxia telangiectasia, and of course, Bloom syndrome. Okay, Bloom syndrome. So these are the etiologies for any leukemia, any acute leukemia. Write out then. Finished. Okay. Now come to the second heading, pathogenesis. For any acute leukemia, remember the pathogenesis is block in the differentiation. So there are some mutations that do not let the blast differentiate. So remember the story which I always tell. There is a king. Okay, he believes that okay, I am the king. I will not give rise to any children any further. So there is block in differentiation. There are some mutations that cause block in the differentiation. So how are you going to remember this? I'm going to just make a chart for you to remember the pathogenesis. So just remember this chart very easily. So if it is ALL and AML, so what are the mutations that can cause it? Okay. So remember hyperdiploidy, translocation 1221. Okay, translocation 1221, hyperdiploidy. Okay, remember again BCR-ABL mutation, MLL mutations. Okay, so these are the simplest one I'm telling you. Okay, BCR-ABL, MLL mutations. So if you're writing this, remember in future you should remember these all four mutations can be associated with ALL. Okay, there are more also, but I'm just writing for the undergraduate. So first two are good, second two are with bad prognosis. Do you remember I told you have to write prognosis also in last? So remember first two are good, last two are bad. Finished. In acute myeloid leukemia, quickly remember translocation whenever we are writing. Remember A21, inversion 16, and translocation 15, 17. Okay. Here you should remember translocation 15, 17 is associated with acute promyelocytic leukemia. It is associated with acute promyelocytic leukemia. Okay. Now, in these translocation, the new update says even if the blast number are less than 20%, you can label them as acute myeloid leukemia. Why? Because definitely there's going to be immaturation arrest and they will develop acute leukemia later on. Okay. So these three translocations are super important. You should write in AML. Okay. Remember this always. Apart from that, yes, we have other mutations also if you can remember. Again, NPM, MLL, and CEBPA. Okay, just remember that NPM, MLL, and CEBPA are all the mutations which can be associated with them. So, coming to the prognosis, these three mutations are intermediate prognosis. They are intermediate prognosis, intermediate to good prognosis because they can be treatable. Okay, NPM is good. Okay, MLL is poor. MLL is poor, and CEBPA is still under evaluation. Okay, but still it is better than the MLL. Okay, right. So that is your just the mutation, the pathogenesis part. So pathogenesis is clear with everybody. So there is something which blocks the differentiation, write down the mutations there and your diagnosis is done. Coming to the diagnosis, third diagnosis. Now, again, I'm drawing the same chart here. So whenever I'm talking about diagnosis, always remember, so I'm going to make it this chart here for you to remember it easily. ALL and AML. Okay, so first let's finish ALL. So whenever I'm talking about ALL, three headings: morphology, special test, and diagnosis of choice. Simple. Morphology. In morphology, these blasts, okay, have a very high nucleus, okay, very scant cytoplasm. So they have a very high, big nucleus, very scant agranular cytoplasm. Okay, so remember, scant agranular cytoplasm, and sometimes the nucleus is so big that cytoplasm is just coming out from the side. These are called as hand mirror cells. So remember the picture of these. Okay, okay, so if they are giving you this image in exam, okay, so first compare them with the lymphocyte or the RBC, and they are approximately 2 times bigger than the RBC. They have a very scant agranular cytoplasm, as you can see, very big nucleus, you can see, okay, and the cytoplasm doesn't have granules. Can you see? Look at this cell, only the cytoplasm is projected from the edges. This is hand mirror cells. This is a very typical morphology of ALL. Okay, so this is very classical morphology of ALL. That's how ALL blast looks. Now, what is the next test? Special test. So special test for ALL is, so for any leukemia, special test is always special stains, which is called as, what is this called as? Special stains in hematology are called as cytochemistry, because it stains certain cytoplasmic granules in the cell. So this is called cytochemistry. And if you look at pass, can you see this dots and blots? So it, this kind of pass positivity is called as dot and blot positivity. If you write this one term, examiner will be very happy that yes, he knows it, and they'll give you marks. Dot and blot positivity. Finished. And what is the diagnosis of choice? Flow cytometry. So you have to confirm that which lineage it is, B cell or T cell, and you have to identify the prognosis. So that is all done by flow cytometry. So diagnosis of choice for your level is flow cytometry, and that finishes the case. That's about ALL. Okay, diagnosis is done. Now let's come to AML. Okay, so when we talk about AML, before we go to AML, let me just finish this chart for you. So morphology, hand mirror cells, special test, pass, which will give you dot and blot positivity. And what is the diagnosis of choice? Flow cytometry. Okay, flow cytometry. That's it. Okay, now let's come to AML. So in contrast to ALL, let's look at AML blast. Okay, so look at these blasts. So compare it with the RBC. These are approximately 4 to 5 times the size of RBC. They have abundant cytoplasmic granules. Some places these granules are fused together. So these fused cytoplasmic granules, okay, so they are primary granules which fuse, and this is called as orod. Okay, this is called orod. Okay, and if you look at these cells, so abundant cytoplasmic granules, moderate amount of cytoplasm, round to oval nucleus, okay, and at places they have orods. So if you see these orods, cytoplasmic granules, immediately your diagnosis should be AML. This is a case of AML. That's it. It's AML. Now, what should be the next test? Special test. Okay, so special test. So whenever I'm talking about special test, guys, remember that whenever I'm talking about AML, no, so we have approximately 7 types of AML on the basis of morphology. So M1, M2, M3, and M4. Okay, and M4. Okay, and M4. M4. They will be positive for MPO. Okay, M4 and M5 will be positive for a cytochemistry called NSC. Okay, and M6 and M7 will be diffuse pass positivity. Yeah, that is, it will not be dot and blot, it will be diffuse pass positivity. It will be completely positive like this. Okay, leaving the nucleus, it will be completely diffuse pass positive. Okay, so for major purposes, acute myeloid leukemias are MPO positive. Okay, so what is the positivity here? MPO positive. That's the cytochemistry stain that you should write here. So what is the cytochemistry here? MPO. And what is the diagnosis of choice again? So diagnosis of choice is flow cytometry. Diagnosis of choice again is flow cytometry. So for both acute leukemias, okay, AML and ALL, your diagnosis of choice is flow cytometry. Now here is the exception to this case, because that can come to you in exam. Okay, so what is this case? So there is a special type of acute myeloid leukemia which is called as acute promyelocytic leukemia. Name itself says acute promyelocytic leukemia. So this occurs because of translocation 1517, which is nothing but PML RARA translocation. And in this case, the arrest occur at the level of promyelocytes. So these promyelocytes, normal promyelocytes have rounded nucleus, but when the arrest occurs at the level of promyelocyte, a lot of granules start accumulating, and later on, what happens is, because of so many granules, the nucleus of this becomes indented. And there are lots and lots of granules here, and many of them will fuse to form so many OR rods because there are so many granules, isn't it? So these so many OR rods together are called as faggot cells. What are these cells called as? Faggots. Okay, so these are called as faggots. So because there's so many granules, imagine you running in the suitcase, when running on a market with so much suitcase. So this granules can rupture, damage the endothelium, and cause DIC. So it's a medical emergency, and they are associated with a lot of faggot cells with indented nucleus, and these are also called as buttock shaped nucleus because there are two big indents, and they are usually associated with DIC. So this is an exception. Why is this an exception? Because the diagnosis of choice of AML is not flow cytometry. It is always FISH. Okay, so you have to document the mutation on FISH. Okay, so FISH is the diagnosis of choice. Either you do FISH or PCR. These are the diagnosis of choice because you have to document this mutation. Only then you can make a diagnosis of APML. Okay, so diagnosis of choice of APML is FISH and PCR. So that is about lab diagnosis. Okay, so everybody clear? Now coming to the prognosis, always I told you the mutation one is prognosis which you can write. Also, in cases of ALL, ALL blast always have a tendency to involve two organs, testis and CNS. So whenever CNS and testis is involved, these kind of ALL patients will have poor prognosis. So testis is present in males. So obviously males are going to have poor prognosis. So male is a poor prognosis in ALL. Age group was 1 to 10 years normally, isn't it? Anything different from that, less than 1 year, more than 10 years, is poor prognostic. CNS testis involvement is poor. Mutations, hyperploidy, hyperdiploidy, and 1221 is good. Others are bad. Okay. Now, apart from that, CNS and testis we told, age we told, and mutations we told. Now, what is the best prognostic marker? Response to therapy. So, if the patient is responding to therapy within 8 days, the blast should disappear. If they do, that means this ALL is having a good prognosis. And if they don't disappear, even after 28 days, it's going to have poor prognosis. Okay. So, ALL, this is the prognostic markers which you can write. Okay, remember that. And treatment, of course, you have to give therapies. You have to give steroid, vincristine. Okay, all that therapies you have to give. So chemotherapies you have to give. Right now, talking about AML, if I'm talking about AML, what is the prognosis? Again, mutations. Apart from the mutations, again you should remember, if there is any extramedullary involvement, so if there is a gum involvement or if there is some other extramedullary involvement, it is a poor prognosis. Apart from that, you have to remember again response to therapy. Okay, so if they're responding to therapy early and there is no minimal residual disease, it's good. If they're not responding to therapy, they're bad. Now if there is more LDH or if the tumor burden is more, then also it has poor prognostic. So like that, you can make a chart on prognosis. Just make lots and lots of charts. And of course, treatment varies in these cases. Okay, so we have 7+3 therapies which we give in AMLs. Okay, so we have cytarabine and daunorubicin based therapies in AMLs. Okay, so that's all, guys, that you have to remember in cases of acute leukemias. Okay, so whenever I'm making a chart on acute leukemias, please remember this. Okay, so quickly remember, just how are you going to write any acute leukemia, just to make a gist of what we studied. Remember, whenever you're writing a question, okay, So read the clinical case first. Read the clinical case, make the diagnosis. If they're not giving you clinical case, you write the clinical details. Okay, you know the clinical details of the patient, now you write. Then you start with etiology. Etiology we have discussed. Once you have written etiology, write the pathogenesis. We have also discussed that. Now remember the clinical features. Clinical features also you write. Okay, so if they're not given clinical features, you write the clinical features. Okay, then diagnosis. In diagnosis, always write three headings. Okay, what is the morpho, what is the special test, and what is the diagnosis of choice. If you write prognosis, even if you don't know prognosis, make a chart and write something. Okay, and treatment, of course, if you know something, right, otherwise you can leave it. Okay, so that's how you approach a case of acute leukemia. So I hope you have understood